Excellent. Well, thanks everyone for joining this webinar. Just to introduce myself, I'm Greg Skinner. I'm a consultant paediatric cardiologist working here in Leicester, which is in the Midlands in the UK. As well as being a paediatric cardiologist, I'm the deputy clinical director of the Children's Hospital here, so it keeps me plenty busy. And I work with Ventripoint. I have been working for the last few years with them just to help develop the software. So I am paid as an independent advisor. Part of the reason for that is I've been using the Ventripoint system for quite some time. I think we started in this centre back in 2015 with the first generation system. So we've had a fair amount of experience with the system, kind of embedded it into our everyday practice. So I'm just hoping to talk to you a little bit about what the system is, what it can offer, why we find it useful, and the ways in which you might find it useful for your practice. So I just wanted to start outlining basically the problem that Ventripoint is here to solve, what Ventripoint actually is, and then I'm going to do a few case studies in congenital heart disease, which is obviously my area of expertise. So if we just come on to the problem, and I think people will be able to sympathise with this quite comprehensively, that assessing cardiac chamber size and function is really quite fundamental to managing heart disease in a wide variety of conditions. And I think in order to get the most out of this tracking, we really need to get baseline assessments. But beyond that, we need to be able to look at progression, and in particular, look at response to treatment, and then look at the indications for surgery and intervention, then follow up after that surgery and intervention to see what changes have been made. So currently, most people are adopting a variety of ways of doing cardiac chamber quantification. I think the thing that's most universally available is just the eyeball assessments, the subjective assessment based on experience, which is valid, but it lacks that sort of robustness, repeatability, and to a certain degree, it might miss out on these small changes. So there are additional things available, such as linear measurements, looking at your M modes, your fractional shortenings, LV diameters. You can use volume measurements, for example, biplane Simpsons, which is probably the most widely used at the moment. And then in terms of assessing for myocardial performance, myocardial definition imaging with speckle tracking is really becoming standard practice now as well. Problems with these assessments are, again, as we mentioned, the subjective assessment and the reproducibility of that. A lot of these methods make some fairly wide-ranging geometric assumptions based on cardiac chambers, which can lead to inaccuracies if you have an abnormal geometry of the heart. They are dependent on getting complete echocardiographic windows of the entirety of the endocardial surface of the heart. And for certain things such as speckle tracking, normal data with different vendors and in children can be a little bit hard to come by. And you also find that there's a lot of inter-observer and inter-study variability. There have been a lot of articles published, particularly on things like biplane Simpsons, volumetric assessments, showing that sometimes that can be quite poor, or it requires a very large amount of training and standardization in order to make it applicable across users. And a big question for me is, what about the right ventricle? So the right ventricle is pretty fundamental for congenital heart disease. We like to think of ourselves in paediatric cardiology as holistic cardiologists, in that we treat both the ventricles. I think the right ventricle presents some fairly unique challenges. It's a complex shape there, which means unlike the left ventricle, which is usually assumed to be a cone shape, it's very difficult to make simple geometric calculations on the basis of that volume. And again, when you start looking at patients, not just with normal right ventricles, but when they have different pathophysiologies, for example, volume overload or pressure overload, the actual shape of the right ventricle changes. So therefore, it's very difficult to account for those with standard two-dimensional methods of assessment. And standard 2D echo doesn't really have a good volumetric measurement for the right ventricle. Currently, again, when we're assessing the right ventricle function, the key measurements that we use are TAPSE and the free wall tissue Doppler. Again, this doesn't represent the entirety of the RV. We're looking at one segment of the right ventricle. And in particular, in patients who've had stenotomies, you can have adhesions, particularly of the free wall of the right ventricle to the posterior part of the sternum, which can make these very difficult to evaluate in patients who've undergone surgery. Otherwise, we use things like fractional area change. But again, this is only looking at a very small part of the ventricle. And it's also been shown that this has a very large degree of inter-observer variability. And when compared to things like MRI, it often doesn't correlate particularly well. People have moved on to using right ventricular myocardial deformation imaging, but at the moment, that's really only looking at septal and anterior walls, which doesn't tell you any information about the inferior and the superior walls of the ventricle. And it doesn't really give you any information about chamber dilatation as opposed to just function. So then what people say, okay, what about a 4D echo? And this is something which has been introduced. I have used it myself. I find that it can be very challenging, particularly on the right ventricle, to get adequate views. And the reason for that, to do a 4D quantification, you need to be able to see all the parts of the right ventricle all the way through from diastole into systole in its entirety. And that can be very, very challenging to do. And particularly if someone's got severely dilated right ventricle, I've even seen hearts where from the apical perspective, it's not possible to fit the entirety of the right ventricle within a 4D scan cone. So it's very, very challenging. And again, the evidence shows that for applicability of 4D volumetric measurements of function, that actually there's a significant proportion of patients in whom it's not possible to get diagnostic images. I think coming back to the importance of the right ventricle, so in congenital heart disease, it's really quite fundamental. It is often the most, or sometimes the only, affected chamber in congenital heart disease. In conditions such as tetralogy of Fallot, patients with right ventricle to pulmonary artery conduits, and those with univentricular right ventricular circulations, such as patients who've undergone Norwood palliation for hypoplastic left heart syndrome. Additionally, we have a subsegment of patients with pulmonary hypertension where right ventricular function is absolutely vital, and it has been shown to be an independent risk factor for survival in patients with primary pulmonary hypertension as well. And I think it's one of these areas where the more we look into it, the more we're finding the importance of right ventricular function for overall health and survival. So we do have some other existing solutions, and really the mainstay of that is with cardiac MRI. This is actually the gold standard for measuring ventricular volumes, including the volume of the right ventricle. However, the drawbacks of MRI are that in some centres there's relatively limited availability. And that's in particular for patients who you may want to do regular monitoring. There's not going to be a lot of centres where you can do a cardiac MRI and then do follow-up based on trial of a drug treatment to see what the response is, because the waiting times and the availability of MRI is quite limited. And in my own patient group, particularly with children, younger children don't tolerate MRI scans, but also there are issues with people with claustrophobia, adults with learning disability, and these patients may end up needing a general anaesthetic to undergo cardiac MRI, which again, not only increases the cost, it increases the risk, the complexity, and again, the availability of that for frequent monitoring becomes much more difficult. There are also some patients who have relative contraindications for MRI, such as having pacemaker or retained pacing wires, both from a risk perspective, but also from the image generation point of view, is that these often can interfere with actually getting good MRI images. And as I spoke to you before about real-time 4D echocardiography, it can provide a complete assessment without those geometric assumptions, but it's very, very challenging. Oh, sorry. Yes. Very challenging to...
Yeah. Because I remember
someone have a question?
Going to the clinic to get a paper for blood work. I was supposed to have it done ages ago.
Hello?
But anyway, I went in and he was...
Yes, so it can be very challenging to get those pictures of diagnostic quality in order to be able to do what you would be happy with in terms of the right ventricular volume analysis. So this is where we come on to Ventripoint and just go through what it actually is. So Ventripoint is an adjunctive system which is used with a standard two-dimensional echocardiogram. Basically, the technology is that you attach a tracker onto the ultrasound probe, which registers the position of the probe in 3D space as you're doing the echo. What this means is that you can then take multiple 2D images from different windows And because they're all tracked within the same 3D space, the software can put those together and use the points that you mark in 3D space, run those through an AI-based, knowledge-based reconstruction algorithm, which has been trained on a library of hearts with a variety of heart disease, and it uses this to generate a 3D volume, just to demonstrate the what the system actually looks like. It does provide all 4-chamber analysis. So it does left ventricle, left atrium, right ventricle, right atrium. It copes with these complex geometric shapes, particularly in patients who have cardiac disease, in particular volume overload. And it's been shown to correlate very well to cardiac MRI findings in various studies. The key technology is it benefits the 2D echo. So again, for those of you who've used 4D echo, you do get a necessary reduction in spatial and temporal resolution due to the limitations of that technology. With Ventripoint, you get the benefit of the detailed 2D images where you have high temporal resolution and good endocardial definition. And you can bring all those points together in order to get this accurate volumetric data. And as we said, the right ventricle, particularly when it's dilated, can sometimes be very difficult to fit within a full scan sector. And therefore, you get multiple chances to acquire the different parts of the heart and put them all together to create your volume. Again, the image catalog that it's been trained on. So the algorithm was trained on a variety of MRI volumes taken from patients with a variety of illnesses. And as you can see, the wide variety of shapes of the right ventricle that you can get with these pathophysiologies. So it's able to cope with these and generate volumes in patients with these disease, and not just as a lot of demonstrations will show you with other technology, show you what the size and shape of a normal right ventricle is. But this is just a video. This is using the first generation system, so it's moved on a little bit here. But it's just to show you the principle, really, that you have a tracker on the probe, and you see that dice there. You can see that the probe is tracked in multiple planes, so in rotation axes and in absolute position. And that's what the software is using to determine, to say, when you've taken one picture, for example, your 4-chamber view, it's in this position, then you do a parasternal view, it's in this position. And because you've co-registered those in the same 3D space, it's able to put those pictures together and create the volume. Once you've acquired your images, this is just to demonstrate how the point placement works. We have multiple images. So for example, a right ventricular study, you'll take 7 standard image planes. You then position these points here. So these are anatomical points. You can see that the brown point is the RV apex, the blue points are the free wall, the green points are the septum. And you do this in systole and diastole for these views. It's relatively quick once you get used to it. So this usually just takes around about 5 minutes for a patient study. And you do this on multiple images. So there was a 4-chamber view. Now we've moved on to a parasternal short axis view here. So again, we find our end diastolic image. We pull over that template. We mark on the various anatomical points. So here we're going to mark on the septum, the edges of the septum where it meets the free wall of the right ventricle, and then the actual RV free wall here. And we do that both in systole and diastole for all these views. So I actually personally find this quite a lot quicker than tracing endocardiums using other methods. And then once we've put all these points on, here we can see a study where I've inserted all those points onto the system. The system doesn't actually use the images at all. It's not looking at the images and doing border detection. It's taking those points in 3D space, and it's using those with the knowledge-based algorithm to then say, do a best fit and create a specific volume for that patient. And as we can see here, once we've generated that, we come up with a 3-dimensional volume of the right ventricle. So you can see where these points have been placed in that 3D space. It's then generated this wire mesh model. You can see these are actually all the scan planes that we used to generate the image, and you can see how they're all co-registered with each other and how you can see them in different planes. We can then look at the systolic and diastolic volumes. We can see the top right, you see the calculations. So it gives you the index volumes, the ejection fraction, stroke volume index, all the usual data that you get off an MRI scan. We can just have a little simulation of animation between the systolic and diastolic image. and then showed the systolic and diastolic images. When you go back to the images, this yellow border here, this is, again, it's not tracing the border, it's not interpreting the actual echocardiographic images. This is overlaying the generated volume just based on those points onto your 2D images, which is a really important way of validating that data. So you can have a look at that and check that the fit looks good to make sure that the information that you're providing is reliable. Again, we're just going to do the same thing. This is the left ventricle. You may say, well, why bother doing this when you can just do a biplane ejection fraction? I think that this actually gives you a much more accurate version. You're not quite so constrained by getting perfect apical views. It's a lot more forgiving from that perspective, and it takes in a lot more data. And again, we can see here, it's generated this left ventricular volume based on these points. Here I've just overlaid these multiple points together. I think I'll take up a few of these and just show you a long axis and a short axis view here. So you can see how these are co-registered together, and you can see, well, actually that long axis view is partially cutting through one side of the ventricle. So although you think you've cut right the way through the ventricle, you may not necessarily have done so. And again, we create this nice volume here, which shows you that transition between the diastolic and systolic images. And again, we have all our volume data. And once again, we can overlay the generated volume over the top of as it's intersecting through these echo planes, and just demonstrate how well this is correlating just based on these sparse data points. Again, when people have actually been and analyzed the correlation between the Ventripoint system and cardiac MRI scan, multiple studies, we find there's very, very good agreement, around about a 2.4% difference for end diastolic volume, 4.4% difference for end systolic volumes, but they correlate well. There's good intra-observer variability. Once again, this is looking at right ventricles and pulmonary hypertension, which shows this really quite close agreement, R squared value of 0.97 between the two methodologies. So again, I think we can see that that when we compare this data to MRI, it's reliable and it provides you with this useful adjunct. This is data actually from our centre, where we took two consultants, both analysing the data, and this is the blind-Altman plot looking at inter-observer variability. And once again, we find very, very good agreement between different operators on this, interpreting the same studies. So moving on to the actual physical hardware, this was the version 1 system which we acquired in 2015. You can see that we've got a very large clunky cart with a magnet on it, and basically you can find to outpatients with this. This wasn't really terribly practical for taking around the hospital with you. And the other disadvantage of the old system was that you had to calibrate it to one specific echo machine, so you could only use it with that machine. Things have moved on, and we got our new system around about 2 or 3 years ago, and this is the new system here. This small tablet-like computer which is on a stand, and really this is our imaging team here. We can see that the size of this is much more convenient, both from the perspective in outpatients of being able to store it safely, but also in terms of making it mobile. This is our clinic echo room. We can see here is our E95 machine. We've got the Ventripoint machine set up right next to it. It's very quick and easy to set up. But I'd say this is in captivity, but now I've been able to use it in the wild. So this is a patient, this image is reproduced with permission. We can see here, this is our intensive care unit, and this is a baby who's on an ECMO circuit. And you can see how crowded the bed space is. That previous system really wouldn't have been suitable to be parked in this space. We wouldn't have had room for it. But with this new, smaller system, I'm actually able to take the system up to the bedside and do these analyses on the sickest and smallest of our patients. And we found that data to be very valuable. Okay, so I was just going to talk to you about a couple of case studies just to highlight the use of the system and the reproducibility of the data. The first one is just to demonstrate a case of RV remodeling post-pulmonary valve replacement. So one of the, going back long-term, the prime uses for this is monitoring the right ventricle in patients falling to trial GFALA repair. So in infants who've had tetralogy of Fallot repair, they're frequently left with quite significant pulmonary regurgitation. And one of the key decisions for these children is the point at which to intervene on that. Preferably, we like to do a pulmonary valve replacement when they're as big as possible and as close to adult size so that we can put an adult size valve in. But we don't want to wait until the RV dysfunction and IV dilatation is such that by the time we do that, the RV can't recover following that surgery. There's always a debate about the timing of the surgery and what's the right time to do this. So this first patient had tetralogy of Fallot, which was repaired using a transannular patch at the age of 11 months. A transannular patch basically means that the surgeon has had to cut through the pulmonary valve and put a patch in front. So these patients almost invariably have severe pulmonary regurgitation. This patient, when they were 12 years old, had an MRI scan. This demonstrated an indexed end diastolic volume of the right ventricle of 129 mils per meter squared and an indexed end systolic volume of 59 mils per meter squared. So different people will have different cutoffs. Sort of a fairly widely used cutoff for indication for pulmonary valve replacement would be an indexed end diastolic volume of above 150 mils per meter squared, or an end systolic volume of over 80 mils per meter squared. So he didn't really fulfill criteria at that point, but he noticed a deterioration in his exercise tolerance over the following 2 years. And actually, we brought him back and we did an assessment with the Ventripoint, where we found that his end diastolic volume had actually increased quite substantially, up to 170 mils per meter squared, and his end systolic volume had increased to 92 mils per meter squared. So this, along with the symptoms, really gave us quite a clear-cut indication for surgery, and he went for a surgical pulmonary valve replacement at the age of 15. Now, one of the advantages of the Ventripoint is that we're able to do quite frequent assessment. And as you can look here, the orange and blue graphs show the Ventripoint assessments over a period of time. We can see the point at which the pulmonary valve replacement was done back in 2016. Prior to that, we did have these increased right ventricular diastolic and systolic volumes, which then rapidly came down and stabilized following that. And here we can see this really quite nice remodeling. He still has a dilated right ventricle, but it's much better than it was before. When we did a follow-up MRI scan 4 years post-pulmonary valve replacement, this is where the X marks are comparing the MRI-derived diastolic and systolic volumes, and shows that it's actually tracking very, very closely. So this provided a lot of reassurance for us that we did the pulmonary valve replacement, we had a substantial improvement in the situation, and we were able to monitor that using the Ventripoint system. The next case is a very similar case, but this is one showing where the RV didn't remodel. Again, a very similar background. This patient had a transannular patch repair at the age of 9 months, and then had an MRI scan at the age of 9 years, which showed a dilated right ventricle with an end diastolic volume of 144 mils per meter squared and an end systolic volume of 85. Again, we saw a reduction in exercise tolerance around about the age of 13, and on a CPEX test, he had a VO2 max of 23, which is only 52% predicted, and an oxygen pulse of 6.1 mils per beat, which is only 57 predicted, which fits very well with a patient who's got impaired cardiac output due to pulmonary regurgitation. We did the VMS assessments at that time, and we found the volumes were actually fairly modest and a bit reduced compared to the MRI scan. Now, this is not unusual at this age that we will see the index volumes changing. And the reason for that is that children undergo this period of rapid growth around this age. And what actually happens is that their body surface area sometimes increases a lot more dramatically than their ventricular volumes. And therefore, we can sometimes see that the volumes stay relatively static, but the index volumes go down. Because of this, and because the symptoms and the impaired cardiopulmonary exercise test, we felt that he was a candidate for pulmonary valve replacement, so he underwent that at the age of 14. Unfortunately, what we see here is that again, on the serial assessment, despite the pulmonary valve replacement, we did see an increasing RV systolic and diastolic volume. And looking at the comparison between the MRI scan and the Ventripoint, we do actually see, again, very close correlation. The MRI scan was slightly larger than the Ventripoint scan, but very much ballpark, but the end systolic volume was very much the same. So once again, this shows a patient in whom we're able to do quite regular monitoring of their ventricular size and function following an intervention. I think we find this very useful, and this informs our practice going forward. Okay, just to show up a few of the references. I'll just say these are some of the studies. This is a study where they used 3D and cardiac magnetic resonance images for the Ventripoint, and just demonstrating that it only takes around about 5 minutes to perform these analyses. It's very quick, very accurate. This one is looking at demonstrating the utility and the reliability on a multi-center study. And again, looking at these in patients with different shaped ventricles in adult congenital heart disease and patients with RV to PA conduits. Again, this is looking at the reproducibility between different operators. And one more, and again, it takes around about a third of the time to do the analysis than it does for doing CMR studies. And again, for those of us who do CMR studies, tracing out endocardial borders, I can tell you that the VMS is a lot quicker than that. And we can actually use the VMS system for performing analysis on MRI scans as well. And I found that it works very, very closely, and it's very quick and easy to do. And again, this is showing the equivalency of cardiac in patients with pulmonary arterial hypertension, showing good intraresolve variability.